Thank you for joining us near and far. Hoping everyone is staying warm on this blustery day across the U.S. This is Malia Villegas. I'm the Director of the Policy Research Center here at the National Congress of American Indians. And we are invited to welcome you to the fourth in a series called the Translation Webinar Series that we've been hosting during this month of November, as well as last year in November for Native American Heritage Month and Diabetes Awareness Month. So we're very excited to bring this to you, courtesy of the Washington University in St. Louis Center for Diabetes Translation Research. And you can see more information about that center at http://cdtr.wustl, W-U-S-T-L for Washington University in St. Louis.org. Again, that's cdtr.wustl.edu, excuse me there. And we're also tweeting this webinar at NCAI PRC for Policy Research Center there. So we're very excited to have a dear friend and colleague of the Policy Research Center, Dr. Kaimi Sinclair, for the fourth in this series called Disseminating Diabetes Research. So I'm going to hand it over to my colleague, Sarah Patulski, to walk you through a few of the logistics for today.
Greetings, everyone. Thank you again for joining us. We wanted to just go ahead and run through some of these logistics. So what you'll see on this next slide is that we have, this is kind of the basic view, minus this NS Sales Solutions. This is kind of what you're going to be seeing. So we'll go to the next slide and look more closely at kind of the controls for attendees. So as you see here, this is kind of how you're going to be able to participate. The orange arrow in the little tab here, as you see highlighted on our screen, is a way in which you can open and close your panel. It'll kind of do something like that, pop in and back out. You'll be able to kind of test your audio. We prefer that you have it set up to use your telephone. So if you could just call in using the number that is displayed on your screen. And your unique audio PIN is really key. So if you're already on the call, please go ahead and make sure that you've dialed in your audio PIN. We do have everyone on mute at this point in time, but as far as engaging with us and being able to speak and share some questions, which we will plan time for at the end, we do have an application here piece where you can raise your hand if you have any questions, and you can also kind of submit text questions through the box that you see here below. And we will be making this webinar available, the recording of it, after this event on our website, so please stay tuned for that. Now at this point, I'm going to go ahead and switch over to Dr. Sinclair, and she will be able to share her screen with us and begin her presentation. Thank you so much, Dr. Kaimi.
This webinar on strategies to disseminate diabetes research. So I'm going to start with a question, two questions. So why do American Indians suffer a disproportionate burden of diabetes and diabetes-related complications? And why aren't they benefiting from what we already know? These were my first research questions when I began my academic career in New Mexico almost 2 decades ago. It's these questions that drove me to pursue a career in diabetes research with American Indians and other health disparity populations. So during my presentation today, I'm going to be sharing some examples of my dissemination and implementation research that I abbreviate as D&I because they're very long words. And many of you may already know what D&I is, but for those of you who aren't as familiar, I'm going to briefly review a couple of definitions before I move on to some examples of D&I research. So dissemination, the targeted distribution of information and intervention materials to a specific public health or clinical practice audience. The intent is to spread knowledge about evidence-based interventions. Often this is done through training or through journal articles or presentations at conferences, through newspapers and the internet. Dissemination research tries to figure out the most effective ways to create, package, transmit, and communicate information about evidence-based interventions among a variety of stakeholder groups. So implementation is defined as the process of putting to use or integrating evidence-based interventions within a setting. So in the picture you can see a boy getting vaccinated and a no smoking sign. So these are kind of public health and policy programs that are being implemented. So implementation research, we try to understand the behavior of the implementers, so decision makers, staff, etc., within a context or within their organizations or communities, and then what contributes to the adoption, implementation, and then integration or sustained utilization of evidence-based interventions within differing settings. So many of you have probably seen this information before, but it takes an average of 17 years to turn 14% of original research findings to the benefit of patient care. So I think this is how D&I research can make a difference in people's lives. This refers only to clinical medicine, I believe, and we have no idea of how or of what the time might be for community programs to benefit from research findings. So while there have been tremendous advances in medical care, we know that there are efficacious and effective programs, drugs, treatments that aren't being implemented, or at least not implemented yet. Here's a couple of examples illustrating the delay from discovery to implementation. One is penicillin that was discovered in 1928, but it wasn't implemented for more than 15 years later. Smallpox epidemic raged in Boston in 1690 and 1702. The vaccine was developed in 1798, and finally the last natural case in Somalia was eradicated in 1977. So imagine the health and quality of life of people and lives saved if we were able to implement what we already know in less time. So this lag from discovery to widespread implementation in public health is a key reason D&I research is needed, because it may help us figure out how to speed up this process. So I wanted to just share with you some of the D&I questions that are of interest to me and how I've framed them. So one, how can we best communicate research findings to individuals and communities in a way that they can actually use them, or in a way that motivates them to use them? How can we work together with individuals, communities, or organizations to sustain implementation of beneficial programs? And how can we take what we know about improving health and put it into practice in a timely manner? So now I'm going to share with you my very first diabetes intervention research that happened to lead to D&I research. And this is quite some time ago, before D&I research was of great interest to some of the funding agencies. So the Strong in Body and Spirit intervention was designed and evaluated by the Office of Native American Diabetes Programs in New Mexico to assess the effects of a culturally appropriate lifestyle intervention on A1C among Native American adults with type 2 diabetes. It was an educational curriculum focused on improving dietary and physical activity behaviors. We had the funding from 1993 to 97. It was evaluated in 8 New Mexico Rio Grande Pueblo communities. It was delivered by trained community health members. Fortunately, participants had about a 0.8% decrease in their A1C. And as many of you probably know, an improvement in A1C is associated with a decrease in microvascular complications. So after the funding was over, the research project was done, we, and fortunately the American Diabetes Association and Bristol Myers Squibb Foundation, were really excited about the effectiveness of the diabetes self-management program designed just for American Indians. So they awarded us some funding to develop an implementation training with the purpose of disseminating the Strong in Body and Spirit program to tribes on a national level. A tribal health worker training model was adapted from the research project for the dissemination and implementation strategy. During the team trainings, teams reviewed the content of the program, the Strong in Body and Spirit curriculum, and then they developed their implementation plan. So we had them go through the who, what, when, where, and how. So when they got back to their community, they'd be ready to go with their plan that they developed at the training. And it was a 4-day training. So we tried to be practical by using the lessons we've learned from the study about potential challenges that the trainees may face back in their communities. So between November 1998 and November 1999, we had 4 regional trainings, and a total of 39 teams were trained, which is 159 individuals from Oklahoma, Arizona, Minnesota, and Oregon. So this was our dissemination strategy, team training. So at the end of the team training, we told the trainees that we would call them in 2 weeks to provide technical assistance and see how they were doing with implementation. And it was also a method where we could motivate teams if they weren't too excited when they got back, or other things took away their time to do this. So during the 2-week follow-up call, we interviewed either the team leader that they had identified at the training or one of the team members. We asked if the team had sought tribal support yet, if they'd begun recruiting participants, and if they'd set a date for their first participant meeting. Then we called them 12 months after the training to follow up. And the trainer, we asked them if the team had actually implemented the Strong in Body and Spirit intervention. So about 59% of the teams 2 weeks post-training had met to plan implementation of the Strong in Body and Spirit program. 46% said they sought tribal support, and 56% said that they began recruiting participants 2 weeks after the training, and 41% had scheduled their first intervention meeting. At 1 year post-training, 67% of teams implemented the Strong in Body and Spirit intervention. We don't know how they implemented it because they weren't there to observe, but they said they implemented it. And they reached, each community reached a wide range of participants, so from 4 to 350 total at 1 year post-training. So we did a content analysis of the team responses, and it yielded 1 main facilitator and 2 main barriers or challenges to implementation of the program. So the main facilitator to implementation reported by the team leader or team person that we talked to related to the participant satisfaction with the program information, the visuals, and the video. So having happy participants kept the community health representatives going and continuing to implement the program. Additional facilitators that they mentioned were team commitment and teamwork, support of an administrator or the tribe, and positive outcomes for participants, so improved A1C. Some of the major barriers mentioned by teams included time and team-related issues. So specific time issues were that they had no time to implement, they were too busy with other duties, there was a staff shortage, or there was staff turnover. Specific team-related issues included that all the people that we trained left their job, too few people were trained, the wrong people were trained, the team leader left, there was a lack of teamwork, and the trainees were nervous about teaching. Implementation and non-implementation sites mentioned time and team-related issues approximately the same number of times. However, in non-implementation sites, the most frequent barrier mentioned was that the team leader had left. We had never done this before, and we assumed that getting a team of people together to deliver this program in their communities was a good idea, because if you've ever done interventions, you know how time and labor intensive it can be. And so we ask people to come to these trainings as a team. But what we didn't realize is that until later, these people that came to the team training may not have worked as a team before in their communities. So it was just a group of people, a group of community health representatives or community people that the tribe got together to come to this training. And then we have them identify a team leader, you know, and they'd never worked as a team before, then their team leader wasn't that invested in being the leader if in a team that they didn't really plan to work with or hadn't ever worked with. So after we did the one-year follow-up with all the teams we trained, I set out to construct a theory of training that might be applicable to the dissemination and implementation of Strong in Body and Spirit. So I reviewed the training literature, and which was mostly in the business and organizational literature. And I found 7 training theories and combined those theories, or reviewed those theories and chose one that I thought was closely related to our team training. So through integration of our results and the adaptation of this training theory, we came up with a new integrative theory for effective dissemination and implementation that might be appropriate for the Strong in Body and Spirit intervention. And this is our new integrative theory of training transfer. It's a theory of training motivation. So it acknowledges and integrates cognitive and social processes of individuals known to influence training effectiveness. So as I mentioned earlier, we trained community health representatives, which is similar to training participants in an intervention study to do whatever it is that we'd like them to do. So the aim of both is behavior change and motivating people to perform some behavior. So I think this theory illustrates a set of individual and situational characteristics that can be leveraged to improve dissemination and implementation of a diabetes lifestyle intervention. And really moving from individual level change to DNI, to the DNI project, showed me the similarities between the individual level and community organization or organization level change. These next couple of slides depict a simplification, of course, of the goals of behavior change at an individual level, and then on the following slide I'll show the goals of behavior change at the community or organizational level. So many of the strategies we use in intervention research and to disseminate and promote adoption of programs, drugs, or treatments are also marketing strategies. We use these strategies to sell our programs to potential users. So, for example, in research, we have to sell or convince individuals to participate in our studies. In DNI, we try to sell or convince communities or organizations to use our program. So if an individual enrolls in our study, we hope they'll like it and it's beneficial. And then if everyone likes the program, we hope they'll continue to use it, tell others about it, and perhaps eventually it will become routine or integrated into a person's lifestyle. So the goals of individual level behavior change are similar to that of community or organizational level behavior change. So as with individuals, if the community or organization decides to try our program, we hope they like it, and we hope it's beneficial for them, but the routinization or integration of the program into their usual care or their practice will depend on the nature and the scope of the innovation or the program. As many of you may know, changing organizational or community behavior, like individual behavior, can be quite difficult. Both require a fair bit of digging around under the hood, so to speak, to find out what drives or motivates people, communities, and organizations. But I think that's what fascinates and challenges me. D&I research can reveal pathways to behavior change in communities, organizations, and systems. In these next couple of slides, I just wanted to share with you some of the translational work I've completed, some of the current projects I have, and some upcoming research, because I'm always looking for partners and collaborators on these grant-funded research. So after the Strong in Body and Spirit curriculum, which was focused on diet and exercise, the participants told us they wanted more information, more on the medical management of diabetes. So they wanted to know, what do these glucose numbers mean? What does A1C mean? Why am I having these side effects from these medications? And then about diabetes complications. So we developed another curriculum called Partners in Care that focused on the medical management of diabetes. Later, after that, I went off to Michigan, and they had a REACH project in Detroit with African Americans and Latinos. And I talked them into letting me adapt both Strong in Body and Spirit and Partners in Care for that those populations. And they hired and trained community people, and I trained them how to deliver the intervention, and they decided to call it Journey to Health. After I left Michigan, I wound up in Hawaii, and we adapted the program, Journey to Health then, for Native Hawaiians and Pacific Islanders. And after we did a pilot study, after the pilot study was over, one of our community partners found some additional funding to keep it going, another round of it going. And the community health clinic actually integrated it into their usual care, and they're still delivering that to their patients now. Let's see. So I kind of have a common approach in all the interventions that I've developed. So kind of my modus operandi is we use CBPR approaches. All the interventions are informed by focus groups that we do before we develop the intervention. They're all culturally adapted. We use stories and analogies to convey messages. They're all delivered by trained community members to small groups of participants in the community setting. And I typically use social cognitive theory as my theoretical framework. Some of the current and hopefully forthcoming translational and diabetes, D&I research, I am starting a program to do the diabetes prevention program with American Indian men, because they're very hard to reach. And in most of the DPP studies that had American Indians in them, only about 25% are men. So they're a bit neglected in weight loss programs. We also have a living donor kidney transplant program for American Indians that's ongoing. We are starting a short project to do deliberative discussions with American Indians about biobanking, and a couple other grants that I'll be submitting soon to do diabetes self-management intervention for Pacific Islanders in Washington, because I looked in the literature and there really isn't anybody doing anything with Pacific Islanders in Washington, and this is the third largest population in the country, and obesity and diabetes are a big problem. And then I'll also do, or propose to do, the diabetes prevention program with Pacific Islanders. So one of the exciting proposals that we have out for review is an implementation research project. And we're going to use system dynamics to help examine the facilitators and barriers in different organizational types to implementation of the diabetes prevention program. So about 1,000+ people have been trained across the country to deliver the diabetes prevention program. All these people come from lots of different types of organizations across the country, but we don't know what the contextual issues are, challenges are for these different individuals in different organization types. So some of our research questions, so how does variation in a practice setting affect adoption, implementation, and integration of the diabetes prevention program? How do contextual and system factors affect adoption, implementation, and integration? And where are those points of leverage in differing types of organizations? So points of leverage refer to optimal places within a system or organization that one could intervene that would facilitate implementation. So often, you know, we have policies that are developed in organizations, but just because there's a policy doesn't mean that it's going to change anybody's behavior. So hopefully using system dynamics, we could identify key leverage points to intervene to assist some of these folks in implementing the diabetes prevention program. Finally, I've got some strategies for D&I research. I'm not the expert on D&I research, but these are kind of my lessons learned so far. So design for dissemination. So dissemination doesn't generally occur spontaneously. You need to plan for dissemination after the research is over. You need to plan before it's over, almost as thoughtfully as you plan for recruitment into the initial study. So find out from your community or organizational partners how they'd like to learn about the results of the study and how this information can be shared with leaders in the community or organization. Second, think about context. Think about the context in which your program is going to be implemented and the resources needed to carry out the program. So will a community with limited resources be able to implement the program on their own? What resources are they going to need to do the program? How can we build capacity within communities to facilitate dissemination and implementation? As I said, we hire and train community members. We try to get to know the formal and informal leaders within communities and try to pay attention to the contextual challenges that might impede adoption of the program. Context, varying needs, motives, and constraints will all need to be addressed in the knowledge transfer process. And finally, one size doesn't fit all. You might need to tailor your dissemination pathways to various user groups. Look for D&I partners. This is hard to do on your own. So we need partnerships to help garner scientific, professional, and tribal or community support for key research results to facilitate their adoption and implementation. Both in intervention research and in D&I research, we need to look for change champions or leaders that can help us in these real-world settings where complex interrelationships among the program itself and the community or organizational structure and values, the external environment, and individuals delivering program are going to pose as challenges. So we need to change champion within the organization or community to overcome the many barriers that there may be to implementation. And look for opportunities to do D&I research. This is kind of new, and people are still figuring out how they can do this, and I still struggle on how I am going to do D&I research. And sometimes it just comes to you, and there's an opportunity that arises, and you take a hold of it. So sometimes a lot of the D&I research has been done in healthcare settings. But D&I can help identify facilitators and barriers to adoption and implementation of programs and services and get the needed information and programs to patients and clients. So in concluding, why do American Indians suffer a disproportionate burden of diabetes and diabetes-related complications? Why aren't they benefiting from what we already know? After 2 decades of conducting research in diabetes, these remain some of my research questions because relatively little has changed. Despite all we know about the management of diabetes and all the tools and technology we have at our disposal to help manage diabetes, we still have populations that suffer a disproportionate burden of diabetes and diabetes-related complications. We have the enormous potential to improve and advance the health of individuals and communities through a greater focus on implementing what we already know. D&I research can illuminate why some individuals and communities aren't benefiting from what we already know. This is why I do D&I research. So I have some resources here if you're interested. You can find a lot more resources within these references, and I can come back to that. But I'd like to thank Malia and Sarah and Daniel for helping put together this presentation. And I have my contact information there. Thank you so much. I really appreciate your time.
Thank you so much, Dr. Kaimi. Wow, we did not expect to be highlighted here at the end, but just really the thought and information that you presented here. Just quickly, I want to offer just a few reflections before we open it up to questions. Again, if you do have a question, please go ahead and use the webinar feature to raise your hand, and we'll go ahead and unmute your line at that point. Or you can feel free to type a question that we can read for Dr. Kaimi here. I was just fascinated by kind of the depth and breadth of work that you've done, and this notion of marketing strategies I thought was very intriguing. One of the models that I know you and others on the phone may be aware of that has really been touted recently for having a lot of impact on particularly Alaska Native health, one that we featured at our mid-year conference up in Anchorage this past June, is the NUCA model of care. And I'm intrigued because they talk about customer owners of their system and thinking about marketing and consumers and how to frame some of this work in that light. It just made some things click for me. I think also in thinking about D&I dissemination implementation research, particularly in diabetes for American Indians, Alaska Natives, I'm just constantly revisiting the fact that so much of diabetes research here in the U.S. has been developed in partnership with communities, Native communities in the Southwest and Arizona region. Some of the early work partnered with the Pima and now Gila River community out there helped to create NIDDK. And so how much of this dissemination and implementation research is really carrying forward so much of that, and the importance of remembering the genealogy. And I really appreciated your emphasis on benefit, that we have to come back to that question in thinking about the impact of D&I research here. So those were a few of the reflections that I had. That theory of training, I think, is very helpful in going, from how do you collect data on implementation, as you featured there, but then how do you take that information to try to improve processes by leveraging research, from business literature, from other kinds of literatures, and think about how we do better with this work. Fascinating data point you shared also about the lack of male participants or trainees in the DPP and the need for more of that work. So a lot of things you triggered for me, certainly, and I think a lot of good information, in learning about your journey on this path. This is a new field for a lot of folks on the phone, I'm sure, and I just appreciate you being open to sharing with us some of that journey and helping us learn together. So thank you, Dr. Kaimi.
Thank you.
We have any questions, Sarah?
We do have one from Momi Fernandez, so I'm going to go ahead and unmute your line.
Hey, aloha. This is Momi.
Aloha.
Hey. Shout out to Malia. How's it?
Hey, aloha, Momi. How are you?
Good, good. It's still morning here, so listen, I just want to say what a nice presentation, and mahalo for Kaimi for all the metaphors that you include and respect for cultural integration. So a couple of things. One is, while you were in Hawaii, were you connected with IMIHALE, the our diabetes research arm from Papu'olalo Kahi? And the other would be, wouldn't it be nice, maybe more of a comment, or I'm sure you've already thought of this, but since your two questions that you opened your presentation with were represented at the end and stating that they're still sort of unanswered, or at least not answered enough for your satisfaction. Native Hawaiians, American Indians, and Alaska Natives alike, having suffered such historical trauma and a change of diet and nutrition, have you entertained or have you been able to measure any native, returning back to native foods and what that does and its effects or impacts on diabetes, and just being able to recognize or try to come up with a measurement regarding historical trauma?
Aloha, Mommy.
Hey, how's it? I know that was a mouthful, right? So
I knew the people at IMIHALE, but we didn't connect on diabetes. So I worked in the Department of Native Hawaiian Health, and Keawe Kohulukula had a grant, and so we got an administrative supplement to do a pilot of the Partners in Care curriculum in the 3 communities where he was doing the Pili-Ohana weight loss program.
Oh, great. Great, yeah.
So that's kind of how that came about. It was just a pilot, so it was like 2 years, and we were kind of done with that. But the historical trauma, no, not so much. But I've been doing, I just finished 4 focus groups with Pacific Islanders here in the Puget Sound region as some data to include in the grant we're going to write to do the diabetes self-management program for Pacific Islanders here. And yesterday I had 8 Samoans, and many were from Samoa, from Western and American Samoa. And we talked a lot about the differences in food, food preparation, and physical activity in both Western Samoa and American Samoa. And so it is going to be a big part of the diabetes intervention, self-management intervention. And, they talked about wanting to start a garden of their own and having some more exercise classes and things like that. So
terrific. That's great. So I would just recommend then that you, even though you say that it was just a pilot, or it wasn't a full-on project at the time that you were involved with the Pili-Ohana, put that on your slide. So then, so then those of us from Hawaii, or those of us that know about Dr. Keawe's research and all that kind of stuff, know then who you really connected with. Because I wasn't familiar with the Partners in Care name. Yeah, I wasn't sure if that was KKV or who you connected with. Yeah, so yeah, put that in there. That'd be great.
Okay, thanks.
Great work, man. I really enjoyed this this presentation, this webinar. Mahalo.
Mahalo. Another exciting grant Keawe just got is one to do hula to reduce blood pressure in Native Hawaiians with uncontrolled high blood pressure. So I talked him into having Seattle as one of the sites. And so he made Seattle one of the sites. So I'll be the co-investigator here, and we'll get some Native Hawaiians to do hula and lower their blood pressure. So that's really exciting.
That sounds like an automatic hookup with the Hawaiian Civic Club up there, because there's lots of hula going on through the Civic Club. Besides other halal, but yeah, that'd be great.
Yeah. Thank you.
All right, thanks.
Momi, this is Malia as well. I just wanted to make one other comment, because I think your point about historical trauma is right on. And I did want to say that we've been working, we have a student on the phone joining in the webinar, Winnette Whitegoat, out at St. Louis, who's been working with us on a translation guide for diabetes context. And one of the topics that we're looking at is co-occurring conditions. So diabetes in connection to cardiovascular disease, in connection to various other health conditions. You know, our people don't just, as you know, experience diabetes in isolation, and I think there's an opportunity for us to bring historical trauma in terms of looking at disease profiles and experiences of diabetes in that context. So I really appreciate that comment.
Hey, mahalo.
Thank you.
Good work, you guys.
Hey, mahalo. Send our best to the islands, eh?
Hey.
Have another question, Sarah?
At this point, we don't.
Okay. Looks like we have no other hands raised. If you do have a question, again, please use your webinar feature to raise your hand or to type in a question that we can raise for Dr. Kaimi.
Rodney. All right, we see Dr. Rodney Herring has a question. We'll go ahead and unmute your line right now.
Hello.
Hey, Rodney.
How's it going, everyone?
Good.
Are you covered with snow? Are you okay out there?
We are covered with snow, but you know the Hawaiian words kind of give me that warm Hawaiian breeze feel, so I feel comfortable now. But we're buried in snow here in the east, so. But all is good, and I just wanted to thank Dr. Sinclair for sharing your research and highlighting some of the things that you're doing, and I think it's really important, the translation or the highlighting of the organizational process. I think that's key and a great means for future research.
Thank you. Mahalo again.
Mm-hmm. But I don't have any questions in particular. Just thankful for, you know, it's always good to hear these things and kind of stimulates thought and creates good research projects moving forward in collaboration. So appreciate it.
Thank you, Rodney.
On that note, Dr. Kaimi, I was wondering, this is Malia, I was wondering if you might say a little bit more about the systems analysis that you put on the table, and just thinking about that point about organizations. You know, I think there's a piece of implementation that really came through in your presentation about the internal challenges, right, in terms of staff turnover, you know, and time and the supports around administration that come up. But I think the systems kind of dynamic is both that internal and external. So if there's any more, and I think this was part of a training that you folks also recently had through the CDTR. I didn't know if you want to say any more about some of that.
Sure. So anybody that's worked in communities or organizations, you understand that there are things external to the individual that you're trying to reach that are going to influence their behavior. And so a couple of years ago, I had the opportunity to go to a systems science in health training put on by NIH and CDC. And I went to the system dynamics workshop for the week. And it was just fascinating to me that there was a program or programs that you could use that could help identify the links between factors that are going to influence behavior within organizations or systems, and also identify the called feedback loops, because, you know, we realize that everything affects everything else. So if you change one thing, you want to know how it's going to change other things. So kind of like a flight simulator. You know, if you're running low on gas, something else is going to happen. And in system dynamics, it can show you what else is going to be affected if you change one thing or two things. So I am partnering with the Washington University System Dynamics Lab, Peter Hoffman, to submit this proposal to use system dynamics in the implementation and we're going to do some, it's called group model building. It's kind of like focus groups in a way, but it's something that we just did with Peter at Washington University, and kind of brainstorm about things that you think are affecting some outcome that you're interested in, and he's able to write it all up on the board in a way, in a kind of a model of how things might work. Of course, the actual system dynamics part is really complicated, and you have to be an expert on how to use the software. But I'm really excited about it. I think we can learn a lot about how things work within different kinds of organizations and communities that affect implementation of fairly intensive programs like the DPP.
Great, thank you so much. It's just such fascinating tools, I think, that are available to try to capture how people and communities live and move in relation to this work. So that's great.
Okay, we have a question from Momi. Okay. Roger. We'll go ahead and unmute the line. Momi, if you want to go ahead and ask your question.
Yeah, I was just thinking, how can we get a copy of this presentation, or will it be available on a website, or what?
Definitely. With Dr. Kaimi's permission, we will definitely send out the link to the actual webinar, which will be a YouTube link, and we'll attach a copy of the PowerPoint as well following the webinar.
Great, mahalo. I'm sure that Dr. Kaimi's mentors and those would be excited to see this, and should be very proud as well.
Oh, thank you.
Yeah.
All right, and it looks like we have another question from Roger. So I'm going to go ahead and unmute his line.
Go ahead, Roger.
Oh. Good. No, this is not Roger. This is one of his case students, El Salad. I have a question for I'm going to butcher this name. Kaimi?
Kaimi!
Yeah. Is there any other tribes in Arizona than the other two that you mentioned, besides the Havasupai and the Tohono?
Can you say that again?
Is there any other tribes in Arizona that you work with, other than the other two that you mentioned?
I'm sure there were. So our community health representative that worked on the project, the intervention with us, the Strong in Body and Spirit program, she did all the training. So we have a list somewhere, but I don't know exactly which tribes sent teams to the training. I'd have to look that up, but I could probably get that to you later if I can find it. It was a long time ago, but I remember the Havasupai coming.
Oh, okay. I just wanted to know because I was like, there's reason why, because there's a lot more tribes in Arizona than those two, and I was kind of wondering why, was this your focus was just on those two? Was there a reason why your focus was just on those two?
No, we didn't focus on just those two. We had regional team training, so anybody that lived around there, so people from New Mexico could come, Arizona, California. So we advertised, or ADA, American Diabetes Association, helped advertise these regional team trainings, and so the teams came to whichever training was closest to where they were. So we didn't focus on any particular tribe, but any tribes that wanted to come.
Oh, okay. Cool. Thank you.
Thanks.
Okay, it doesn't look like we have any more questions. We do have a few more minutes. I did want to very much thank Dr. Kaimi for this research. Like I said, we are going to be sending this information out to all the registrants in terms of the YouTube recording here within the next day or so. It sometimes takes a little bit for the webinar to process, but we'll do our best to get it out there in the PowerPoint. And we'll also send links to the 3 webinars that we had last November. Dr. Rodney Herring, who's on, you just heard a few moments ago, gave a wonderful presentation last year. Dr. Jamie Bartkus and Dr. Kimberly of the National Council on Urban and In Health also gave one, and Dr. Tassie Parker. So we'll include links to those in case you'd like to have a look at some of the past webinars in the series. Again, we want to encourage you to take a look at our Center for Diabetes Translation Research, cdtr.wustl.edu, and we are one of a total of 7 Centers for Diabetes Translation Research funded. 3 of those have a particular focus on American Indian Alaska Native Indigenous health because there hasn't been the greatest output on that front and a better need for translation research. So that's a big part of what we do. If you know of any scholars, Indigenous scholars or scholars with a demonstrated commitment to research in American and Alaska Native Indigenous contexts, please have them let us be in contact with us through that link. We do have different resources and supports through that center for mostly researchers who are post-doctoral level. And also we've been tweeting at NCAI PRC as far as this webinar goes. So I think are we out of no more questions? Okay, well thank you all very much for taking the time. And again, Dr. Sinclair, really appreciate your work and your leadership on this topic, and we look forward to learning with you as we go forward in this. So Kleana, everyone, and have safe and warm holiday season.
Thank you.
Thank you.
Thank you.